Hello, we are going to cover mental status assessment all the way from basic to more advanced tools. So this is going to be an in-depth overview, and it's also going to help you to better understand some of the terminology we use in the mental status assessment. So our objectives are to identify the aspects of the psychiatric mental status assessment, differentiate between abnormalities in appearance, emotion, thought, cognition, judgment, and reliability, and improve psychiatric mental status assessments. So areas that we are going to cover include the general appearance, which include behavior, attitude, and speech, emotion, which include mood and affect, thought, which includes thought process and thought content, cognition, judgment and insight, and reliability. All right, so first, let's talk about general description, the appearance. So we're looking at the patient's age and gender. Do they look younger or older than their stated age? We're looking at their body build. We want to know, are they frail? Are they muscular? Are they obese? That's going to tell us a lot about their health. We're also looking at their appearance and dress. So are they appropriately dressed? If it's negative 20 degrees outside in wintertime, are they coming in shorts and a t-shirt? Or are they wearing minimal clothes? Are they wearing a lot of clothes on a hot summer day? These are things we want to be assessing. Do their clothes reflect their mood? Some people might wear bright pink from head to toe, or they might wear all black from head to toe. These are important things to note. Are the clothes clean and wearable? Are they disheveled? Do they appear childlike, or do they appear bizarre? We want to look at their grooming, their hair, skin, and nails. Are they dirty? Are they well taken care of? Do they look like they have some cut marks or burn marks? Do they look like they maybe have an infection? All of these things. Is their hair falling out in clumps? Is their hair really dirty? Have they not bathed? A lot of times with depressed patients, we may see matted hair because they don't get out of bed for so long. These are things we want to be looking for. And looking for physical abnormalities. So any signs of substance use, pupil size, bruises, needle marks, cuts, missing teeth, etc. Signs of anxiety such as moist hands. Are they sweating? Are they tense? Are their eyes wide? All of these things we should be assessing in their appearance. And as we can see, these three people on the side have very different appearances, body builds, ages. Some are disheveled, some are well put together. All of these things we want to make note of. All right, so here is just an example. If we look at this patient on the right side, this is not a real patient. Think about, before you read this description, think about some ways that you would describe him. And now if we look at the description, the patient is a 23-year-old male who appears his age. There's poor grooming and personal hygiene evidenced by foul body odor and long unkept hair. The patient is wearing a worn t-shirt with an odd symbol looking like a shield. He later might tell you that this is related to that he believes there's antivirus protection from it, from people who can access his mind. So this is something you might see in psychiatry. All right, so moving myself all around here. Motor behavior. So these are movements and things that we look for with movements. We look for signs of drug side effects called abnormal involuntary movements. We're also going to look for things like level of arousal, alertness, signs of delirium, hypervigilance. If somebody is taking substances, they might have a decreased level of arousal. We want to be assessing that, or they may have an increased. They could be increased alertness. We want to assess their gait and posture, their eye contact and body language. If somebody is often looking behind you, they could be responding to external stimuli, things like that. We want to make note of. Are they suspicious? Are they having suspicious body language? We want to make note of these things. We also want to make note of their mannerisms. They could have compulsions, which is an irresistible urge to behave in a certain way. We see this sometimes with OCD. They feel like they have to flick a light switch 3 times before they walk out of a room or things like that. They might also have rituals. Do they have any tics or involuntary abnormal movements? Any psychomotor retardation, which is slowing, or activation, which is fast movements, or are they agitated? Are they angry? They might have disinhibition of impulsivity or disregard for social convention. So that just means, are they impulsive? Or do they not care about rules? Are they going against the rules of the hospital, the rules of the unit? Do they not care? All of these things are important when we're assessing their motor behavior. So some examples of motor behavior dysfunctions, a common one is called akathisia. This is an inner restlessness with inability to sit still, and this can be a side effect of many antipsychotic drugs. And the patient just really feels like they can't sit still, just this inner restlessness, and that's how they'll describe it. They can have, there's all these other descriptions as well: catatonia, extreme motor inactivity or hyperactivity. Dystonia is a twisting or repetitive movements or abnormal fixed posture. A tremor, which is when they have an unintentional rhythmic ache. Automatation is a spontaneous verbal or motor behavior with patient awareness, so they can make noises without their awareness. And choreoathiosis, I'm not actually sure how you say that one, but that is a movement disorder characterized by episodes or attacks of involuntary movements of the limbs, trunk, and facial muscles. And again, this picture is just a good overview of all those things that we are assessing when we are looking at the motor behaviors. All right, so this is called, I'm going to put myself here. This is called the Abnormal Involuntary Movement Scale. So this is something that providers do. So psychiatrists, nurse practitioners, they will do this test. But it's important for us to know what it is, to know what we're looking for when we're looking for these side effects. So the Abnormal Involuntary Movement Scale tests for tardive dyskinesia and severity. So this is a syndrome characterized by abnormal involuntary movements of the patient's face, mouth, trunk, or limbs, which affects 20 to 30% of patients treated with neuroleptic medications. And we'll have some examples of this in the following slides. This scale takes about 10 minutes to complete, and it's usually given every 3 to 6 months to monitor the patient for the development of tardive dyskinesia. Usually this happens around 3 months after the initiation of a neuroleptic medication, but in elderly patients it can be sooner. So this scale has 12 items. Items 1 through 10 are rated on a 5-point scale. 1 through 4 assess orofacial movements. 5 through 7 assess extremity and truncal dyskinesia, and 8 through 10 assess global severity. Items 11 and 12 are yes or no questions related to teeth or dentures, because that people might move their mouth because of teeth or dental issues. And again, completed by a trained clinician, and this is what it looks like over on the right side. All right, so let's look at an example of these abnormal involuntary movements.
Try not to be distracted by the movements in her lower face. Please focus your attention on her eyebrows. In the second segment, notice this patient's blinking. Try not to be distracted by the other facial movements. Notice the blinking takes place during the finger tapping exercise. This is one of the activated movements. The 1-point score reduction used by some examiners is not recommended. The score on the screen does not include any such reduction. The second body area to be scored upon completion of the AIMS examination is that of the lips and perioral area. The examiner is looking for evidence of puckering, pouting, and smacking. This segment features a rather subtle lip movement. Notice the sucking in the lower lip. You may think this movement is minimal and give a score of 1. This would be too low. Remember, 1 is used for borderline movements, movement which may actually be extreme normal. This movement is too persistent to be extreme normal and should be scored 2. Please notice the frequent movement of the mouth in this segment. Segment 5 shows obvious perioral movements. This man's movement disorder also involves the neck muscles, which should be scored on Section 7 of the examination. For now, focus on just the perioral movements. Notice the frequency, also the amplitude, that is to say, the size of the movements. The third body area to be scored on the AIMS examination involves the jaw. The examiner is looking for biting, clenching, chewing, mouth opening, and particularly lateral movement. Lip movements caused by jaw movements should not be scored. Clenching of jaw muscles can be noticed in front of this man's ear. Segment 8 illustrates a slow chewing movement. Notice the jaw movement in this segment. The lip movement is secondary to the jaw movement and should not be scored. The patient in segment 10 has constant jaw movement. Notice the frequency and amplitude of the movement does not change. It is the same before, during, and after the activating exercise of extending the arms. This is a good example of why a point should not be subtracted when scoring movements detected during an activating exercise. Segment 11 is quite short and will be shown 3 times.
Okay, so let's talk about the general description, the speech category. So the rate that a patient talks can be at different rates. We have pressured, which goes down to rapid, which goes to regular, which goes to slow. It's a scale. Pressured speech is a rapid speech driven by an internal sense of urgency. So that's going to be pressured. It's going to be very hard to get a word in with these patients. They're just going to go on and on. Rapid is when they're speaking fast, but you can still get a word in and have a discussion with them. Then there's regular, and then they're slowed. Our tone and prasad, I don't know how you say this, prasadi is the loudness, our pauses, and our rhythm. So we can have dull, monotonous speech, which is a depression. There isn't that kind of change in tone. It's just monotone, the same kind of sound as they speak, monotone. And then they can have loud, whispered, or tremulous speech. We also want to look at the fluency and rhythm. So the cadence, this is the way their voice gets higher and lower as they speak. We're going to look at the latency, so pauses before speaking. Spontaneity, so the ability to make small talk. Circumstantial, this is obsessive traits or anxiety. So you may see this in some of the assessments that you do. That is what that means. And then tangential is more what we see in a mania, right? They just go off on a tangent, and we'll look more into this later in this discussion. We also look at articulation. So dysarthria, which is difficulty speaking caused by brain damage. They can have stuttering, they can have an accent. So some more examples, we talked about dysarthria. They can have echolalia, which is meaningless repetition of another person's spoken words. They can have neologism, which is making up of new words. And they can have clang association, which is grouping of words, usually rhyming, based on similar sounding sounds regardless of logical grouping. So let's look at an example of pressured speech.
Hello, I'm Dr. Warwick. It's nice to meet you.
Hi, Dr. Warwick. I'm really glad you're my doctor, Dr. Warwick. I've been to a bunch of other doctors and a bunch of other hospitals and some clinics and stuff. And I just think that maybe they weren't thorough enough. Like, they just need to be really complete in all their tests and their studies and stuff. Because I'm going to be complete with all of, like, my complete medical history, of course. I'll give you anything that you need, like what medications I'm on and what I have. Like, I have high blood pressure, probably caused by my high cholesterol. I have both. And I also have allergies. I'm allergic to everything, like cats and dogs and trees and everything. Cats are the worst, though, for animals, but I think I'm allergic to all animals. And I'm even allergic to dust, which is crazy because dust is everywhere. But I have insurance. I know insurance. You probably want to know that, too. I'll give my insurance card to your nurse because she'll want to see that so she can do all the paperwork. But I have insurance and thank God, because if you don't have insurance, it's like impossible to get insurance, because especially if you have allergies like me, because then you've had them like forever. But so also, I mean, it's not just insurance. I do have a job. Like, I work. I sell cars. And sometimes I like to help people because I'll give them a good deal on a car. If you ever need a good deal on a car, I can totally give you a good deal on a car. And you're a doctor, so you help people too. So that's good, because I think that's what sort of makes the world go round, is like helping people and everything. But if you have to put me into a clinic or something, or keep me in the hospital overnight, I can do that too. I just have to get time off from work, which is fine. I can totally do that. And have people come. I can call family and they can bring me my clothes. That would be fine. But getting time off from work should be easy. And you work really hard too. Do you get time off from work?
Okay, and let's look at another example of some of those speech abnormalities.
You're Doctor Who, diddly dang, waddly dang. It's good, isn't it? Do you watch that? It's fantastic. That
Okay.
Now, what
John,
is? Yeah,
can I ask you how old are you, John?
Oh, no, only as old as the woman you feel, aren't you? Eh?
Right. Okay.
When you feel, aren't you? Eh?
Right. Okay.
You know, weight the man's heart is to his stomach. Oh yeah, fantastic.
So how old would that make
Food
you,
for
John?
the soul, nice bit of soul, yeah.
Right.
Eh? No, a bit of fish. I'm hungry. You got
Right.
any food? Any food round here? Oi, down there, you got any food? I'm starving now.
They won't be able to get you any food.
Nah,
Shall we perhaps? I'll tell you what.
Okay,
let's perhaps think about
let's
food
get back to
in
this.
a minute.
Let's
Yes, that's a good idea.
This is important. This is why I'm going to talk to you about this.
Okay.
Tell you what's
so
going on.
Tell me a bit about this then.
Well, this is the work I've been doing. You know,
Right.
this is really important, and it's my cure for cancer.
Okay.
That's what it is. You know, it's all written down here.
Right.
Well, it's not written down. It's here, and it's at home in my books at home.
Right.
What I get from the papers is I get sort of clues as to what
Right.
what I'm supposed to do, and how I'm
Okay.
supposed to get the other clues so I can hone it down and come up with a final
and how
thing.
long, John, has all of this been going on? Would you
It's been going
say?
for ages now.
How long would you
Absolutely
say?
ages now. Well, I've been up a week.
About a week?
But this week I've been working really hard at it.
'Cause
It's
before-
been going on longer than a week, but I've
Right.
been working it really hard for this week.
Could you about it then?
Okay,
Tell me
right.
what's
Well,
going on.
I've got my various bits and pieces in. I find things in the papers like the football results. You see,
Right.
they need adding together, and then I have
Okay.
to find some other information on this page. There'll be some pages and page numbers. I have to
Right.
add those together and take it away from what's on there. Yeah?
Right.
So that's how I do that, and then
what does that number do
you
then?
find other things. That number corresponds to numbers I've got on me. on my chart. I've got a big chart on my wall,
Right.
and I find that number, and then that
Okay.
adds up to something else. And it's all there. I mean,
Done all
that
this with all the numbers in the chart. Where will that leave you? What is it you're headed for?
Well, it's the cure for cancer, isn't it? That's
Cure
what it
for
is.
cancer.
Cure for cancer.
Okay,
yeah.
how's that going to work then?
Well, how it works is God tells me, that I'm doing a really good job,
Right.
how great I am, and how fantastic it is I'm working at this,
Okay.
and I just keep going at it. I don't
Okay.
stop. I don't stop.
Okay.
Yeah.
Well, I guess before we get back into that, I guess
Well, no, I don't want to get back in. I want to talk to you about it
Yeah.
now. Can we talk about it now, please?
I guess, John, what I'm wondering is whether this might be a sign that you're not very well at the moment.
No, I'm fine. I want to talk about this. You seem to want to change the subject, so I
Yeah.
don't want to talk to you anymore. I've had enough of you, and I've had enough of being out. I want to talk to somebody else. I want to talk to the boss. I want to talk to your boss. Where's your
Right.
boss?
John, I am the boss.
Well,
I'm the
you're a shit
consultant.
boss, and I want to talk to somebody else. There must be somebody else.
All right, so still under the general description, there is also the attitude of the patient. So are they cooperative or uncooperative? Are they presenting hypersexual? Are they agitated? Are they pessimistic? Are they having over dramatization of situations? Are they very self-centered, not really being able to think about anything else outside of themselves? Are they controlling? Are they hostile? Are they guarded? Guarded means that they are not telling you a lot, and you might be asking them questions of why did you come to the hospital, and they might be like, don't worry about it, I don't want to answer that. They don't want to answer questions. They're unsure if they can trust you, things like that. That would be an example of guarded. Then the next category we have is the emotions. So we have two separate things. We have mood and we have affect. So mood is how the patient says they feel. When we are talking about mood in our assessments or our notes, we can use quotes. This is the best way to show how the patient feels. When you ask a patient, how are you feeling today? Whatever they say, that's their mood, regardless if it's how they seem to look. And we'll get into that. So they could say they're depressed, in despair, irritable, anxious, angry, expansive, euphoric, empty, guilty, hopeless, frightened, or confused. Mood can be labile. It can fluctuate, or it can have alternate rapidly between extremes. An example, they can laugh loudly one minute, then be tearful and in despair the next. Now, the affect is what we see as healthcare providers. So this is the physical expression of a person's immediate feeling state. It's typically focused on facial expressions and may or may not be congruent with mood. So what this means is, again, mood is what the patient says they feel. Now, if a patient tells you that they feel sad, that is their mood. They feel depressed, they feel sad. But for you, you might see them, since they've gotten here, they've been laughing and joking with people. They've been having a really good time, been social. So maybe their affect is not sad, right? It cannot match. It could be the same if somebody says that they feel happy about something, but yet they're just always tearful and saying that they are anxious or something like that. Like it doesn't match up, and that can happen as well. All right, so different types of moods. Euthymic means normal display of emotion. Hyperthymic is intense display of emotion. Irritable is easily annoyed or angry. Anxious is feeling worried or nervous, typically over an uncertain future or outcome. Expansive is an extreme or elevated mood that may last for an extended period of time. Can also have an elevated or euphoric mood, which is an excited state of intense happiness. We can have apathetic mood, which shows or feeling of no interest, enthusiasm, or concern. We can have dysphoric, which in a profound state of unease or dissatisfaction, and they can also be depressed. When it comes to affect, things that we look for are quality and range. So we want to know the depth and range of feelings shown. And this again is on a scale. Start going from the highest, which is an elevated, down to full, to constricted, to blunted, to flat. A lot of people get blunted and flat confused. So if you take nothing away from this slide, when we get down to that, take a note. So elevated, intense, or labile affect are feelings of a widespread spectrum of emotions in a more vivid and profound way than normal people do. So they're feeling these emotions in a very intense way. There is full, that's normal. You have a full range and quality of emotions. Constricted is a reduction in an individual's expressive range and the intensity of emotional responses. So it's just a reduction. Now, blunted is a dull, and that's how I always remember it. If someone is blunted, their emotional reactions are dull. Or restrictive response, where a person's emotional response is not as intense as normal. So we can go from constricted, it's just like a little bit less than normal, then blunted, it's dull, but flat is no response to emotional stimuli, including facial expressions and tone of voice. People who are flat, they might find out some horrible news, like somebody they really care about is in the hospital or something, and they just have absolutely no emotional response whatsoever. So that's going to be flat. To be a true flat affect, virtually no signs of affective expression should be present. The patient's voice should be monotone, and the face should be almost immobile. Note the patient's difficulty in initiating, sustaining, or terminating an emotional response. And we'll see some examples of this later. Motility is the shifting of emotional states. So this goes from a scale with the highest being labile to supple or stable, and then to sluggish. So labile is that unpredictable, uncontrollable, and rapid shift of emotion. Example might be uncontrollable crying or laughing at an inappropriate time or situation. With fluctuating, this is more of a mood swing. Supple and stable is normal, and sluggish is slow shift of emotions. Appropriateness to context. So does the person look the way they say they feel? If they say they're sad, but they're off laughing with friends and joking, are they really sad? Or maybe they are sad, but it's just not appropriate to the context. All right, so let's see an example of an elevated affect.
Of course I'm happy. I've been feeling on top of the world for a week now. It's amazing. I'm a supermodel, and I'm named after a world-famous supermodel who has been on the cover of all the famous fashion magazines around the world, even in Brazil, in case you didn't know that. You probably don't realize how important I am, do you?
All right, so let's see an example of a labile affect.
I've been feeling on top of the world for a week now. It's amazing. There are all these people. I can hear them walking outside the door right now, and I'm just trying to figure out how to ship my clothing to Milan, and they're standing there like, oh, I can hear her heels just outside the door. It's very irritating. I don't know if you can just let them know.
And let's see an example of a flat affect.
Bill is trying hard. My name's Sam.
All right, so now we're going to get into thought, and we have thought process and thought content. So how do we assess thoughts? We can ask questions like, what's been on your mind recently? Are you worried about anything? Have you felt that life isn't worth living? Do things seem unreal to you? Do you think anyone is trying to harm you? And are there thoughts that you have a hard time getting out of your head? And what we're assessing with these questions are different thought disorders in a sense. What's been on your mind recently is looking at the way they're feeling. Are you worried about anything is focusing on what they're focused on. Have you felt that life isn't worth living? We're assessing suicidality. Do things seem unreal to you? We're assessing for hallucinations. That's in a very kind of light way. If you're working inpatient with psychiatric patients, you should be asking straightforward, are you suicidal? Are you having thoughts of suicide? But this is a nicer way to put it if maybe you're not dealing with suicidal patients. Do you think anyone is trying to harm you? We're looking for, is there any abuse? Could maybe delusions, right? Are there any thoughts you're having a hard time getting out of your head? We're looking for those obsessions, that rumination of thought. This is how we can assess for those things, by using questions like this. So the thought process can be goal-directed and logical. This is a linear progression of thought without veering from the subject at hand. It can also be circumstantial, so the inability to answer a question without giving excessive unnecessary detail, but does eventually return to the original point. And we'll see examples of these on the next slide. Tangential, this is when they wander from the topic and never return to it or provide the information you requested. Loosening of associations is jumping from one topic to another with no apparent connection between the topics. A flight of ideas is a rapid shift from one topic to another. Perseverations are a repetition of a particular response, such as a word or phrase, regardless of the absence or cessation of a stimulus. And thought blocking is abrupt cessation of speech without explanation in the middle of a sentence. So a logical idea thought. This is when a person wants to make a point to someone, and to make that point, they connect logical thought leading up to a final point. So let's look at an example of this. So they start, I was home. They want to get to, and now I'm here. A logical progression is, I felt some pain, so I told my son, and he called an ambulance. So this is, say, a patient's in the emergency room. This is a logical thought of how they got here. Now we can have a circumstantial idea thought. So where each point is logically connected but veers from the goal. This person is able to self-correct and get back on, oh, that's supposed to say track. It says treat, but get back on track. So a circumstantial idea thought. I was home. I felt some chest pain, so I told my son, maybe you know him. He's a doctor too. He always worries so much. What was my point? Oh yeah, and now I'm here. So this is a circumstantial idea thought. Now let's look at a tangential idea thought. So here we'll be able to see a logical connection to the thoughts, but the goal is forgotten entirely. And here we feel that if we do not interrupt and help the patient out, they will never get to the point. So I was home. I felt some chest pain. So I told my son, he's really great. If only he'd settle down and have some children. Do you have children? I have 5 boys. So you can see we have to redirect it back, right? That's tangential. And they never come back to that point. All right, so with thought, there's also other abnormalities of the thought process. So speech and thought are connected. So these are some key terminology that we used when we talked about speech earlier in this discussion. But just to remember that if they're talking in this way, that means that their thoughts are also having some abnormalities in processing. So I won't read these again, but just so we can make that connection. So thought content refers to what a person is thinking about, their ideas, beliefs, preoccupations, and obsessions. Thought can be logical, coherent, illogical, and even incomprehensible. Thoughts can range from a rapid flight of ideas to a poverty of ideas. So we also have perceptual disturbances in our thought content. So this would be hallucinations. This is perceptual experiences without external stimuli. So they can have auditory, visual, tactile, taste, and smell hallucinations, or they may be normal. Some hallucinations can be normal in states like if you are in a drowsy state right before you fall asleep, or if you are in a semi-conscious state preceding wakening. There's also magical thinking in children. When young children report visual hallucinations, a lot of times, not all the time, but a lot of times, this is their imagination. So we also have delusions. There's a lot of different types of delusions on this slide, but this is a false fixed belief that has no rational basis in reality, being deemed unacceptable by the patient's culture. So Somatic delusions are delusions that one's body function, sensation, or appearance is abnormal. Patients can have delusions that they have an arm missing or something like that. Somatic delusion. They can have delusions of grandeur where they believe they have superior qualities such as fame, wealth, or supernatural powers. They can have paranoid delusions, which is a delusion of mistreatment, usually persecution, like people are out to get me. Delusions of reference, whereas an otherwise insignificant event is misconstrued of having a special meaning towards that person. Delusions of thought insertion, thinking that someone is externally placing thoughts inside their head. Delusions of thought control, believing that somebody is, the patient believes they're being controlled by an outside party. Delusions of thought broadcasting, where they think their thoughts are made known to everyone in the world. Eremanic delusions are when they believe they're a prominent figure or superstar is in love with them or in a relationship with them, when that's not the case. And nihilistic delusion is where they believe that nothing is real. So some other abnormalities of thought content include obsessions. These are repeated, intrusive, and unwanted thoughts, images, or urges. Compulsions are the repetitive behavior or mental acts in response to obsessions. Preoccupations are the patient's absorption with his or her thoughts to such a degree that the patient loses contact with external reality. It can range from absent-mindedness to severe suicide or homicidal ideation. They can have phobias, which are persistent fear of an object or situation. They can be suicidal, homicidal. They can have depersonalization, which is loss of a sensation of identity, where a person's thought and feelings are no longer felt to be their own. Or they can have derealization, a change in the perception or experiences of the external world to where it feels unrealistic. All right, so this slide is one of those slides that contains advanced practice tools, but it's interesting to know about, especially when we are providing care to these types of patients. So you will not be doing, most likely, the clock test or the intersecting pentagon test, but they are interesting to know. And same with world backwards or serial sevens. Usually providers are doing these things, but it's good for us to know what types of things are being assessed. Cognition can be remembered by goal cramp, which just stands for all these different things that are listed below. So we have consciousness, which can go from alert to drowsy to lethargic to stuporous to comatose. The orientation, they can be oriented to person, place, time, situation. All four. They can only be oriented to 3, or they can be oriented to 1 or 2. Attention. So to test the attention, a provider will ask the patient to either spell world backwards or to use what's called the serial sevens. So they start at 100 and they ask the patient to subtract 7 and keep doing that. And they usually do it 5 times to see. And that one can get a little tricky. It's a little tricky, but that is the way they would test it. They may name objects or have them repeat words or sentences. They may look at calculations. To test the right hemisphere, they're using that intersecting pentagons and also the clock face. And you can see, we won't be diagnosing these things, but it's interesting to know. We can see a normal clock, and then we can see this clock, and it's like the numbers at the top are spaced out a lot, and this shows an early Alzheimer's disease. And then we have this other clock where the numbers are all jumbled together, and that's going to be a late Alzheimer's disease. So it's an interesting test. And then same with these intersecting pentagons. You see the template, you see a normal elderly person, and then as they go down and they vary drastically from that beginning one, you can see one of the ones in case B, it's actually a square. It's not even a pentagon. And as it goes down, it changes drastically, and that kind of shows what stage of Alzheimer's. And again, we won't be diagnosing these things, but just a very interesting thing. There's also abstraction. So explains similarities between objects, understanding simple proverbs. So providers, again, this is something a provider would do, asking things like, what does the grass isn't always greener on the other side mean? And see if they can put it together. They'll look at memory, so immediate, repeat after me, or short term, what were the words? They'll say some words at the beginning of the interview, do their interview, and then ask for those words at the end. They'll check something called praxis, which is engage, applying, exercising, realizing, or practicing ideas. And if impairment is suspected, what the provider will do is something called a mini mental status exam, or a MOCA, and this will test memory, immediate, recent, long-term calculations, funds of knowledge, abstract reasoning. So then we can look at insight. So this is awareness and understanding of a situation or illness or available choices, so they can have full insight, partial limited insight, or no insight at all. Patients' capacity to acknowledge or appreciate their illness, associate the implications and consequences. So when determining patients' capacity, that is something that, again, providers do, and they look at situations specifically when it comes to a legal form of capacity. And patients having trouble with capacity can be due to drugs and alcohol, dementia, cognitive problems, psychosis, severe mood problems, somatoform disorders. So this is when they experience physical body symptoms in response to psychological distress. So with insight, there is a summary of 6 levels of insight, which is as follows. There's complete denial of the illness. There's slight awareness of being sick and needing help, but denying it at the same time. There's awareness of being sick, but blaming it on others, on external factors, or on organic factors. There's awareness that illness is caused by something unknown in the patient. There's an intellectual insight, so admission that the patient is ill and that symptoms are failures in social adjustments are caused by the patient's own particular irrational feelings or disturbances without applying this knowledge to future experiences. And then there's true emotional insight, where there is emotional awareness of the motives and feelings within the patient and the important person in his or her life, which can lead to basic changes in behavior. So then we have judgment. So this is the process of consideration and formulation that leads to a decision or action. So the patient's capacity to make appropriate decisions and appropriately act on them in social situations can be excellent, good, fair, or poor. An assessment of judgment is best made by obtaining a patient's history, and there is no correlation between intelligence and judgment. There's also reliability. So upon completion of an interview, the reliability of the information that has been obtained. Factors affecting reliability include intellect, honesty, are perceived, how we perceive their honesty, and motivations, psychosis and organic deficits, and magnification and understatement. So now everything we've learned and everything we've talked about, we can look at 2 different examples. So we have a mental static exam. This is our manic episode over on the left side, and then our depressive episode over on the right. And you can if you want to pause this video and just look at them and think what you would write for appearance, behavior, speech, mood, perception, cognition, insight, and thought. Then you can compare it with this slide if you would like, but this can just show you the different ways that we can be assessing these things and how they change based on how the patient presents. All right, so case study. Let's watch this video, and as you're watching it, think about these topics on the side that we talked about: general appearance, behavior, attitude, speech, emotion, mood and affect, thought, process, content, cognition, judgment, insight, and reliability. And if you want to jot down some notes, you can do that, but just see what you see from this video.
Anyways, seriously, Sophie, like, if it's you that did this, I swear I'm not gonna forgive you this time. Anyways, I don't hate you forever, but if you can just, can you give a kiss to Snowball and Fluffy for me? Tell them that Auntie Katie, did they get the thing? Anyways, I think the other thing is just hanging up on me. Hello? Hello, are you there? Did you pick up? Oh, maybe the mission.
Hello there. Hi. My name is Dr. J. I've been asked to speak to you today. Do you mind if I ask you a few questions?
No, that's fine. Anyways, I know that my sister probably put you up to this. I was just on the phone with her. I was leaving her a message because she didn't answer, because she probably knows that it was me that was calling. Anyways, sure, go ask me whatever questions you want, but I don't have very much time. Can I just let you know that at the outset here? And my sister probably thinks that I'm bipolar again, which is not true. Every time I just get happy, she doesn't understand and she wants to destroy it for me. Seriously, is it a crime to be happy? No, I don't think so.
So, would you describe your mood as happy at this point?
Of course I'm happy. I've been feeling on top of the world for like a week now. It's amazing.
First of all, what is your full name?
I am a supermodel, and I am named after a world-famous supermodel who has been on the cover of all the famous fashion magazines around the world, even in Brazil, in case you didn't know that. You probably don't realize how important I am, do you? Well, I just signed a contract yesterday with Versace. Isn't that amazing? $1 million contract, so I have to get home and buy a ticket to Milan. Anyways, my name is Katie, and I live in Toronto, and I used to work in retail, but not anymore.
Okay, and what brings you to the ER today, Katie?
I told you my sister is a tyrant, and she probably put you up to this. She probably wants me to be here. You don't understand, but my sister is like this goody two-shoes. Her name is Shelly. Sometimes she goes by Sheila, who knows why. And she just likes being the good one in the family. I'm always the black sheep. Anytime she sees me having like a smidgen of fun, she wants to sabotage it. But now I have one up on her because I feel great.
Have you seen a doctor in the past? Have you had any diagnoses or do you take any medication?
I would say more like misdiagnoses. Yeah, I've had like diagnoses and pills, and psychiatrists don't know anything. Anyways, yeah, so I was diagnosed with depression, and that's probably true, but then somebody said I seem like I'm bipolar, which I'm not. I'm just happy. Like, is it a crime to feel good? Is it a crime to just be happy every once in a while and move out of my miserable existence? I don't think so. Anyways, if you have more questions, I have to go. I told you, I have to buy a plane ticket to Milan, and I have to go and meet some very, very important people. I don't think you realize how important I am right now. So...
Okay, so it seems like you have some important things to do or important people to meet with, but I just wanted to ask you a few questions to make sure everything's okay, and then we can talk about that, okay?
Yes, fine. Go ask your questions, but I told you I have to be out of here soon.
Okay, my first question is, do you think that you have any special talent or special power or special purpose on Earth?
I mean, I've always been incredibly good looking. And you probably don't know this about me because we just met and you didn't know my name before. But I am actually friends with a lot of very powerful, very, very, very famous people. Just in case you're not aware, I am friends with Justin Bieber and Lady Gaga and Katy Perry. And I forgot to call her back, but Madonna called me yesterday. And she just left a really long message, so I have to call her back. I just forgot. And let me just write that down for a second. And then there's Michael J. Fox, who he and I text all the time. He has a brand new TV show. I'm not sure if you've seen it, but I might do some modeling or like a guest appearance on that one too.
Okay, so it looks like you have a lot of important people that you know, but I was just wondering in terms of a special talent or a special power, do you think that you have anything like that?
Well, I mean, clearly I was born to be the most beautiful woman on earth. The downside of that, though, is that it's about to cause World War III.
How do you mean?
Well, don't spread this around yet, but yesterday, Obama let me know that he's going to go to war with Europe because he wants to be the one to do my bidding.
Do you feel that you need less sleep or feel rested only after a few hours of sleep?
But yes, I told you, of course, I don't need any sleep at all. Seriously, I don't know if you've seen my schedule here, but I have so many important things to do and people to call back and all of that. Who has time to sleep? Seriously.
So how many hours of sleep are you getting?
I don't even think I'm getting any sleep at all. It's amazing. No, seriously, it's so many things to do. Who cares? I can sleep when I die, right?
So another question I wanted to ask you, do you feel that your speech is really, that you're talking really fast these days, and other people find it hard to understand you because you're talking that fast?
Well, I mean, probably, but I'm always really talkative. Like, I'm a very, very conversational person. That's what helped me realize my full potential in my life. And so, I mean, I'm like this all the time. I'm very talkative, and it's not my fault if people can't keep up with me.
When people are feeling that happy, sometimes they do certain things that they wouldn't normally do, like spending too much money, anything like that?
I have to be spending a lot of money right now, clearly, because I had to get a whole new wardrobe. As a supermodel, you can't just go around wearing what you had from H&M. So I had to get a whole new wardrobe. I spent, I think, about like $4,000 on my visa yesterday. Wardrobe and makeup, of course, too. And I'm gonna have people to do that for me very soon. There's that, oh, and of course the internet said that the supermodels mostly drive Cayennes, Porsche Cayennes. I think that's the way that you pronounce it. So I have to get one of those too. I have a dealer looking into it for me.
Okay, and another thing I was wondering is that...
oh, that reminds me, actually. Sorry.
Yeah. Okay, what I was wondering was that sometimes people in such a mood have an increase in their libido, and they might have sex more frequently. Have you noticed anything like that?
Well, I mean, just wait until I get to Europe. Of course, I have an increased libido because I'm feeling good, and that's when, you know, your whole feminine power comes out. It's amazing. It's the most beautiful woman on earth. That's sort of my duty, right? But I'm actually sort of like trying to restrain myself until I get to Milan, because then I have all of these men, like real, like Italian men and other Europeans who are there working in the fashion industry too, who will just admire me like I'm supposed to be admired.
Okay, and do you feel that you know you're doing your activity level has increased? You're working on many different projects, and you're investing your time in these pursuits more recently.
Yes, of course, I told you I have 10 million things to do. When you have a meeting with Versace in the morning, you just, you can't put that on the back burner. I have to get this plane ticket. My assistants aren't ready yet to help me organize all of that, so it's all on my shoulders. It's me that's doing all of that. So yeah, I have, and I told you, like, look at this schedule. It's crazy. You probably can't even read it. It's like, look, Saturday, I have to pick up this extra suit. Well, I'm not even going to be here, so I'm going to have it ordered and sent to me in Milan, so I have to look into that, like how somebody actually ships clothing to my hotel room. I have to get...
Okay, so it looks like you have a lot of ideas going through your head. Is that right? Do you have many different ideas or thoughts, like going through your mind, many at a pretty fast rate?
Yeah, I mean, I feel like my mind is moving at like 1,000,000 miles a second. Like yeah, there's so much to keep track of right now.
And I would imagine it would be difficult for you to concentrate on things. Do you think that you're getting distracted easily?
Well, the problem is, if it was just me, it would be fine. But there are all these people. I can hear them walking outside the door right now, and I'm just trying to figure out how to ship my clothing to Milan, and they're standing, like, I can hear her heels just outside the door. It's very irritating. I don't know if you can just let them know to stop, because I really have to get this done, because my first class ticket is open on the window at my computer, and so if I don't get that to that one in time, they only give you like a 30-minute window, right? So if you can just ask them to stop tapping outside and stop. Can you actually, do you mind, can you just go right now? I think I'm done answering questions right now.
I'm sorry you feel this way. I have just one other question. Can you let me know what you would do if you left the ER at this point?
What, are you dumb or something? I told you I have to go home and buy my first class plane ticket to Milan. I have a meeting with Versace in the morning. It's a $2 million contract, okay? And the ticket is there waiting on my computer screen. I just have to put in my visa number and buy it. My sister has interfered enough, and you're part of this whole thing, okay? I don't like you anymore. I don't want to talk to you anymore.
Okay, thanks for talking to me so far. I'm just going to talk to my team, and I'll be right back, okay?
I can't wait here. I don't have time to wait here.
All right, so here is our information. Miss Katie Holmes is a 32-year-old female who appears her stated age. Appearance is remarkable for wearing revealing clothing, likely designer with excessive makeup. Behavior is hyperactive and agitated at times. Speech is pressured and with an increased rate, often loud. Mood is described as happy and over and on the top of the world, and affect is elevated and euphoric, not appropriate to situation. It is also irritable in parts and quite labile. Thought process is disorganized with apparent flight of ideas connected to grandiose delusional themes. There's no suicidal or homicidal ideation. Thought content has grandiose delusions. Perceptions appear normal. Insight is poor. Judgment is poor. Wants to fly to Milan in this state, which can lead to unfortunate outcomes. Also, patient is exercising poor judgment with finances. All right, so now we did one. Let's try one more. We're going to watch this one. And again, thinking about all those different things we talked about, watch it, write down what you think, and then we'll look at the answer key on the next slide.
Hi there, my name is Dr. J. I've been asked to speak to you. Do you mind first that you sit over there and I sit over here? Thank you. I'm a doctor who can help people when they have problems with their thinking and emotion. Do you mind if I ask you a few questions today? Let me ask you some basic questions. What's your name?
Bill is trying hard. My name is Sam.
And could I ask you, whereabouts do you live?
In the knowledge land, a man of the world, heaven and hell.
I heard that you live on campus. What are you studying?
The philosophy of computers. The world is corrupted. Bill is all.
And what brings you to the ER today?
The evil is in some people. Other people are angels. Bill is evil. Evil is him. You can't come in here. Just shut up.
I noticed that you were talking to someone. Who is that?
No one. No one is here. Ask your questions, Dr. Man.
Can you tell me if anything's bothering you?
It's the evil men. The evil men in Santa. The symbols. Bill has the Thunderbolt weapon.
Sam, I understand you were brought here because you took out a knife and this caused a disturbance at the university. Can you tell me a little bit about that?
Bill was my friend. The evil ones told him to make my life hell. He wants my money. He wants to make my life a living hell.
It sounds like this is distressing for you. I'm sorry to hear that you're going through this.
It is hell. That it is. Thank you for asking. You are a good doctor.
Sam, do you think Bill or other people are following you, spying on you, or trying to harm you in some way?
It is Bill. It is Bill and his army of demons. They follow me around, try and take my money. There's a flying camera following me. There's a camera in my bathroom mirror. They think I don't know. Those fools. I have 5 locks on my door. I sleep with my knife. I push my couch up against my door.
And why are they trying to harm you?
Bill has the Thunderbolt weapon. That'll suck the life right out of me. I think the evil one has him. I will still try to defend myself. But they are evil.
But why are they after you in particular?
I am in particular. I don't know. The evil one wants me dead. I think that's what it is. I have to fight them off. They are evil.
Do you think you get messages that are meant for you in the TV, newspaper, or radio?
Messages. Messaging system. Microsoft Messenger. I don't get messages. But the evil one controls the TV stations and the newspaper. You know that? You know. What's the point in all this? The point in all this is not the point you're trying to make. Why are we in this room? Bill wants us in this room.
I want to help you with everything that you're going through. Thank you for your cooperation so far. Let me ask you, do you think that you have a special power or purpose?
I don't. They do. They have the Thunderbolt weapon. Their purpose is to make my life hell until hell freezes over.
Do you feel that people can read your mind or hear your thoughts?
Bill can hear my thoughts. That I know about him and his evil one. He tries to take my thoughts. I draw the shield symbol to keep him from reading my thoughts. It's like antivirus. ABG, McAfee, Norton, you know?
Do you think that anyone can put thoughts into your head or take thoughts out of your head?
Sometimes Bill puts bad thoughts in my head about bad sexual things. He can also take my knowledge. I know a lot. You can take it. I need antivirus. Do you need antivirus?
Sometimes people can hear sounds or voices when no one is around. Have you ever had that experience?
Bill is talking to me right now. He talks to me all the time. He says that he is going to kill me with the Thunderbolt weapon. He says I am a bad person and deserve to die. They comment on everything. Everything. They comment on everything. They tell me I can't make a good sandwich. They tell me I can't type when I'm sending an email. I hate them.
Are the voices asking you to do something bad, such as hurt someone else?
Santa Claus is there for Christmas. Sometimes Santa Claus gets angry and tells me to kill Bill with my Swiss Army knife.
Are the voices also asking you to do something such as hurt yourself?
No. No, I want to live. Everyone wants to live and let live.
If you left here today, do you think you will still hurt Bill?
I don't want to. I don't want to hurt anyone. I'm a good person. But if Santa Claus keeps bugging me, then I have to. I want to free Bill. Once he is dead, he'll be free from the evil one. Bill was my friend once. He used to be my friend. I will kill him today.
I also want to ask you, do you sometimes have the experience of seeing things that other people can't see?
I see everything. I can't see Bill and his evil one. Only hear them, never see. I see Bill at school. He's pretending he isn't doing anything. That scoundrel.
How long have the voices and the thoughts about Bill been going on?
In the spring. In the spring. No. In the summer last year, I broke up with my girlfriend. The evil one started bothering me. In the spring and the summer and the sun, you know? Then I was sleeping less. I was eating more. I was depressed. I was low. Then the voices started. And they started following me. Squeaky sounds at first. Then the voices. Back and forth. It's getting worse. They're getting louder. Last week Santa Claus asked me to kill my friend Bill. Stab him. Liberate him.
Is there anything that's stressing you out more recently?
I got a letter from my university. I think Bill is influencing them. They want to kill me. They say that they are going to expel me if I don't finish my courses.
I'm wondering, do you think that all the stress and these voices may have been caused because of your recent breakup and this letter from the university?
Bill is outside this room right now. He has a thunderbolt weapon. Why are you keeping me here? Why are you wasting my time? Time is precious.
I just want to ask you one more question.
I think the evil one has gotten to me. I thought you were an angel sent by Santa, but I can see the evil one has gotten to you too. You have to let me go home. I need to get out of here. Are you with the evil one?
Sam, I'm really trying to help you, and I thank you for your cooperation so far. I need to talk to the team, and I'll be right back.
All right, so this patient is a 23-year-old male who appears his age. There is poor grooming and personal hygiene evident by foul body odor and long unkept hair. The patient is wearing a worn t-shirt with odd symbol looking like a shield. This appears to be related to his delusion that he needs antivirus protection from people who can access his mind. Patient was cooperative initially, but towards the end, there were no abnormal psychomotor movements. His eye contact was poor throughout with some intermittent piercing stares. There is slow, halting, and monotonous speech. Thought process was disorganized with tangentiality and loose associations. Thought content had bizarre persecutory delusions and delusions of thought withdrawal, insertion, and broadcasting. Perception consisted of auditory hallucinations, which were command in nature with homicidal ideation. Patient is responding to internal stimuli. Insight is poor. Judgment is poor. He wants to kill his friend and is acting on delusional pretext. All right, and these are our references. So thank you for watching, and I hope you found this helpful. Thank you. Bye.